But we got there in the end. I will get it sorted by next week, guys, so I do apologise. Anyway, this is a very interesting case, and I would love to hear as many people's opinions as possible. So, this lady, maternal history is a gravida 1 paranaut. She was an unbooked pregnancy, and she had no obstetric or midwifery care in the UK. She came to the country 1 week prior to labour starting and didn't obtain access to any maternity services in that time. Her BMI was 18 at her booking when she was 40 weeks. She had a previous peptic ulcer. She's an O negative blood group, but her virology and scat was NAD. And that's pretty much it when it comes to her history.
Does she speak English? Can you communicate?
Yeah. She speaks good English.
Okay. Next slide.
Yes, please. Okay. So at 42 weeks, 40 plus 2, she came into triage contracting 2 and 10. And this is where, obviously, we had to do her booking assessment. Her contractions were sort of mild tightenings at that point. So she was booked in triage. They sort of disintegrated a little bit. And so she was sent home. Didn't have any examinations or anything in triage just because she was just very mildly tightening. The day after, she came back. She was found to be 2 centimeters dilated, early stages of labour, contracting sort of 1 to 2 in 10. And so she was sent home again. She returned later that evening. She was contracting more frequently. Was found to be 1 centimeter dilated. Was ketonuria with 2 pluses of ketones. So the plan was to admit her, administer some fluids and some antiemetics as well, because she said that she'd been vomiting throughout the day. At 2100, she swam clear like on our antenatal ward. At 22:10, she had Dagmar, you're not on mute.
No.
At 22:10, she had a sweep performed, and because she was contracting, no prostaglandins were given. But also, they wanted to allow 24 hours post-SHROM before we started to induce her. 3 to 4 hours later, she was re-examined, found to be 4 centimeters, and therefore transferred over to labour ward. We go to the next slide. So, she's now admitted to labour ward. She's 28 hours prom, but with no prostaglandins given due to the fact that she was contracting sort of irregularly to regularly over the period of time. And this is your baseline CTG that was undertaken. So baseline 120, variability is quite minimal, but could be cycling. No accelerations, but we know that she's actually in active labour, so wouldn't necessarily be concerned or be looking out for these at this point. Possible little deceleration there on the sort of second in contraction, but otherwise, would we say okay?
Yes.
Perfect. Okay, if we go to the next slide. So this continues. So baby starts to pick up. So we're seeing some cycling, good sign of a baby that's not hypoxic. Good variability. Baseline remains still stable. Possible accelerations. Would anybody else disagree, or happy to move on?
Yeah, we move on.
Lovely. Next slide. Okay, so at 02:57, she has an epidural sited, and at 3 o'clock in the morning, the test dose is given. And as you can see, her blood pressure and her pulse were normal. This was the same as her booking, but that was only done sort of 2 days prior. So yeah, no major concern. So this continues for a little while. We go to the next slide. So arguably, don't know whether they actually classify, as they don't technically go below 15 beats for more than 15 seconds. but could be, if you look very, very, very carefully with a magnifying glass, could be seen as decelerations with those contractions there. But she's got an indwelling catheter inserted, and Ivy Hartman's, her first bag is started at 03:25. Blood pressure and pulse remain normal. We go to the next slide. CTG classified as normal at 4 o'clock in the morning. Does anybody agree or disagree?
Agree.
I wouldn't say completely normal, but like from the previous one, these shadows make me think to be cautious, really, that there might be some chemo coming.
Yeah, and also, even though it's not technically a 20% increase, our baseline has actually gone up as well. If we went back, it sort of was at about 120, 125, and now we're bordering on 140, but sort of settling more in the 130 mark. So it's a very, very minute difference, but something that could very easily be missed, specifically at 4 o'clock in the morning, but definitely something to keep an eye on. So if we continue. Still quite similar. Baby's had sort of reduced variability now for around an hour. So does anybody want to recommend what we might do in this situation? No?
Just continue the labor. Nothing to do.
Nothing to do, but also, Emmanuel, a little bit of maybe some stimulation, slight abdominal.
Little bit of what?
Huh?
Pardon? I thought they've introduced. I thought you said have they not done any form of intrauterine resuscitation before now?
So they've given fluids, but
Yeah.
what's fluids going to fix? On
Position? Have they changed position?
Yeah. So I'd go more with sort of position change.
So position changing, you don't want to stop the contraction, so you just continue.
Yeah. Bit of stimulation, maybe. It's like abdominal palpation. This baby's had not reduced, but has been quite reduced variability for the last hour now. So you'd expect to see some form of cycling at this point, even in labour. However, nothing that would be too necessarily concerning at the moment. We go to the next slide. Okay, so it's now been an hour and a half with this variability, arguably I would say at 5. She's contracting sort of 1 in 10, and good resting tone is reported and it's being palpated. Any suggestions? Okay, we'll move on. We go to the next slide. So at 05:20, she was re-examined and actually found to be 3 centimetres. I think presenting part at this point was around -2. So the plan made with the midwife was for an obstetric review. At this point, the unit was incredibly busy, so it was difficult for them to get round to seeing this woman. And I think the registrar came in at around 7 o'clock in the morning. At this point, bear in mind, we've got a little bit of what could be cycling there, so a bit more of increased variability around the sort of 5:20 mark, and then sort of decreases again. But we've had that stimulation from the fetal scalp as we've been doing the examination, so we've got a reassuring, nice sign that baby's actually doing well. It's probably going through a slightly prolonged sleep cycle and whatnot. Next slide. Can we go to the next slide, please, Dagmar? Thank you. Perfect. So blood pressure remains the same, pulse still remains the same, and temperature remains the same. Arguably, again, you could sort of see where you're getting those contractions, that we are getting some decelerations, although quite minute in terms of significance. Quite minute in terms of significance. If we go to the next slide, this does continue for another 30 minutes. Anybody concerned?
Not really, no.
Stop it. Perfect. Okay, if we go to the next slide. How about now? Registrar comes in and reviews at 7 o'clock in the morning, and states that the not for Sinto until CTG normalizes. Mr. Naguib, if you're happy to continue, would you want to start Sinto on the previous CTG?
On the previous slide, you mean?
Yeah.
On this one, no, but on the previous one, if you go back one time, no, I wouldn't, no. On this, yeah, on this, okay, but yeah, the next one, no.
Okay.
Yeah.
So chemoreceptor decelerations is the thing that's sort of coming to mind here. We are getting them now with every single contraction, and also the reduced variability within the contraction is something that's also says to me that this baby does not need Sinto to be started. Dagmar, did you want to make a comment? You're on mute. You're on mute, Dagmar. Okay, should we move on to the next slide? So at 0730, some blood-stained liquor is noted. Blood pressure remains normal, same as pulse and temperature. And as you can see, the CTG continues to be reduced variability with some what look like shallow decelerations. Anybody want to start Sinto? Anyone happy to start Sinto on this?
No, Sinto shouldn't be started on this.
Sorry, Erica. No, I agree. No.
Perfect. So do I. I agree. I dislike the fact that this baby has spent the profound amount of the evening and the night shift with reduced variability. We did get fetal scalp stimulation that caused baby to respond to it, which is a reassuring sign. However, for all of the periods in between and those periods of rest, this baby is resting for a really significant and prolonged amount of time in between, which could be a sign of that this is sort of baby's normal. We unfortunately do not have any sort of medical or maternal history for her pregnancy, so no previous CTGs were performed before she came to the country that we could see in her antenatal notes or anything like that. So it's a really difficult one to sort of use the previous comparison for, which just makes it more and more complicated. But yeah, I definitely agree with you guys. I definitely wouldn't have started Sinto on this trace. That's for sure. If you go to the next slide.
My concern, Cara, in the previous one is that the chemoreceptor is associated with no variability nearly for, I think now going for 2 hours or so, isn't it?
Yeah.
Or So I would have done a VE and seen what is the progress and seen the scalp stimulation effect.
Absolutely. I think our previous VE was done at around 5 o'clock in the morning as well. And when she was found to be 3. So it's been, again, another 2 hours of reduced variability with within the contractions, within those decelerations, as well as without them. So yeah, definitely something that we wouldn't want to stress this baby further if this baby is telling us that they're stressed at the moment. You go to the next slide, Dagmar. So we're definitely getting something here. Baby appears to have picked up in terms of variability. However, baseline is now sort of in that sort of segment up to around 150, possibly due to activity. Obviously, this baby's been at rest for quite a significant time, so that could absolutely contribute to the baseline being raised, because we all know that baselines tend to be lower at a state of quiescence as opposed to when they're much more active. But yeah, we would continue, I think, with this one, if you're happy to go to the next slide. Back down to our reduced variability again. So at this point, this is our handover time between that 8 and 8:30. So at this point, we're going to be thinking about those human factors, the midwife that's been taken over, that's been with her all night, probably handing over. Fresh eyes are going to appear in the room, and hopefully we'll have a plan of action as to what to do next. So if we go to the next slide. So baseline increase again, possibly now to around 150, bordering on 160, although looks like it's coming back down to normal. At 9:10 in this morning, the midwife has moved the patient to left lateral, just to try and help with the variability as what is documented, and seeing if that makes a difference to the CTG and the activity of the baby as well, which is all that we sort of can do at this point, other than do an examination, although not due for another sort of 15 to 20 minutes. So if we go to the next slide. The blood pressure's gone up, 137 over 104. Mum is now tachycardic at 108, and her temperature's significantly increased, but not quite yet on the pyrexic line of 37.4. Doctors come in and do a ward round and say, okay, let's do a VE. Let's start Synto if it's necessary, and do some PET bloods just in view of her high blood pressure. At 09:40, she's examined, remains 3 centimeters, and she's consented for Synto to start. Anybody not want to start Synto? Or are we happy to now that the variability looks slightly better?
The baseline has increased, I think, 20 beats, isn't it?
Yep. More than that. So I think the original baseline when she was first put on the CTG, Miss Inigi, was about 120, 125. We've actually had an increased baseline of up to and over 30 beats per minute. And she remains the same. And the cervix has been pretty much the same dilatation for about 2 days, 2.5 days.
Yeah, yeah. Go on, Iman.
Yeah, I was going to say, well, there's no wrong or right way here. It's all about discussing with the woman, taking her. I mean, the background here is obvious. This would have no information about this woman. She's 40 weeks plus. She's coming from Nigeria. And so again, you want to find out what are they thinking? Because I'm sure the woman and her partner also probably at this point are wondering what's going on. And then you discuss with them and find out this is what is going on. We're not making progress. At least the V has not changed. We are having a rising baseline now. Temperature is creeping up. We can't say the baby is hypoxic at this point, but then baby is telling us also that I'm not as comfortable as probably you guys, would think. So it's either we need to intervene, and the intervention is either we are going to put a Synto so that we can make progress, and if they don't want that and they want to go for cesarean section, you put it across to them and let them, help you out in the decision making. And if they are not keen to go in the direction of bailing out of continuing the vaginal process, then of course you can think of cesarean section. Again, if we are thinking of chorioamnionitis at 3 centimeters, the tendency is with the baby that we obviously don't have enough information about, antenatal information about this baby, you're wondering how far can we keep pushing this until vaginal delivery. So for the clinician, you are thinking, I may be thinking of cesarean section here, but then you have to put it across to the parents to make an input about what they would prefer, and then you make a decision. Yeah.
I mean, personally, looking at a 4 centimeter earlier in the night, now we are 3. I would love to have the clinical picture in context here and say to myself, she has been contracting 2 to 3 in 10. She has not gone far. The CTG is evolving hypoxia. I have another 7 hours to go. I personally, don't like to stress the baby, number one. Number two, stress the uterus to have a postpartum hemorrhage. I still believe most of our postpartum hemorrhages, leave alone this session is about hypoxia or not, or about CTG. Most of obstetric outcomes is due to our reluctance to interfere early, due to fear from the system. We are always afraid that somebody will say we haven't started Sinto. We are always afraid that somebody will say you haven't given enough time or something. I mean, we don't try to put the clinical picture into the context and the examination VE-wise. Again, I have worked with people who come in the beginning of the night and do VE and make everybody 3 centimeter and section everybody in the beginning of the night so they can sleep. So I don't want to go to this extreme or to this extreme. The extreme that sections everybody early to sleep, or the extreme to achieve a vaginal delivery at all costs. I think the middle roads have saved many people, really.
Thank you. Can we go to the next slide, please, Dagmar? So at 09:50, the second bag of Hartmann's has been started, and at 10 a.m, Sinto is started at 3 meals per hour, as per obstetric plan. We go to the next slide. So Sinto is increased to 6 at 10:30. Maternal temperature is now 37.9. So an IV paracetamol is given. The anaesthetist has had to be called because this patient has quite difficult veins, and the plan is for a septic screen. Blood pressure's come down slightly, but her pulse is still raised. And the plan is to also give some IV antibiotics as well. Baseline clearly significantly higher than it was when we first started, considering it was around 125, and it's now sitting at, I would say, 145, 150, at points up to 155. Anybody want to turn the Sinto off? Dagmar, if you're talking, we can't hear you. You're on mute. Can we go to the next slide?
Cara, why do you ask if somebody wants to turn the Sinto off?
Well, I just think we've now got a septic mother. We've got a baby that's sort of getting the repercussions of possibly that, as well as a possible infection. Although she's contracting, I think we've had a baby that's possibly been under stress for a prolonged period of time, a mother that's remained the exact same dilatation for 2 days, although she hasn't been contracting regularly. This woman clearly wants to continue with the vaginal delivery. However, if you're putting additional stresses on the baby, if the baby is already stressed, I personally just wouldn't add additional stresses to it. specifically when a mother is also septic, and that's clearly having an impact on the fetus at the same time. So the baseline at this stage, for example, goes up to 160, and yet the Synto is still increased to 12 mils per hour. So we've got a mother that's becoming unwell, as well as a baby that's seeing the repercussions of it when they were stressed already in the first place. But yet we're still increasing the Synto and adding even more stress.
Okay, well, why I ask is because maybe not increasing the Synto. The whole idea of the Synto is to achieve adequate uterine contraction. But the point is, if you are stopping Synto, it's either you're making a decision to deliver that baby abdominally, or because if you're thinking of chorioamnionitis, the solution is not to leave the baby there and turn off Synto, because you don't want this baby to remain there forever. So it's either we are getting on delivering this baby, or we need to get that contraction strong enough to drive us to full cervical dilatation. It's either we're doing that, or we are delivering abdominally, because the CTG has not really become worse yet. I mean, CTG basically, we know its baseline is high, but it basically is a CTG of chorioamnionitis, which we know is probably what's happening already. So actually, we can actually discuss abdominal delivery, and if the woman doesn't want that, then we need the contraction strong until such a time where we have adequate uterine contraction. Then we can either maintain it, or if we have abnormal CTG, then we can think of turning it off. But if you just turn it off when CTG is still normal and you're leaving the baby in a hostile intrauterine environment without delivering abdominally, that's not helpful.
I second Emmanuel in this. You know, it's one of two. Either you as a clinician is thinking that we are achieving something and we are continuing, and I'm not in favor of this in this CTG. But if I want to stop Synto, maybe the question would be stop Synto and deliver. That's the answer, really. So stop Synto and deliver. I completely agree. From maybe when we examined, and it was 3 centimeters. So I examined. I felt like she's not progressing. I felt I'm going through to choreo. I felt that whatever I am delivering. So I wouldn't stop the Synto and stay in the room, personally, as well.
No, it does make perfect sense. And I guess we've still got the reassurance that the variability remains normal and the baseline is at this point stable. I just the fact that we clearly want to go for vaginal delivery, but we're continually increasing the Synto. She's now contracting 4 and 10, and the baseline has gone up. We already had an evolving hypoxia.
Yeah, I agree with you, Cara. We shouldn't be putting the Synto up at all or increasing the Synto. So we should have bailed out now for nearly 2 hours. Yes.
Yeah.
So we should. Yeah.
We go to the next slide, please, Dagmar. So this is where it starts to become a little bit more interesting. At 11:19, so just at the very blue bar here, the first one, she's moved to a left lateral position. At 11:30, her temperature has come down to 37.6, which was obviously escalated, and the CTG remained classification as suspicious. And this was all prior to IV antibiotics starting, just because there was a delay getting her cannulated because of the difficult veins, trying to get bloods from her because of her difficult veins as well. So yeah, I would argue at this point, considering our baseline in the previous slide was sort of sat at 155, 160, that this could be classified as a subacute hypoxia for about 10 minutes, purely because this baby does not spend any length of time at the baseline for that first segment of this slide. So at this point, please tell me if anyone would disagree with me. I would be at least reducing the Synto if that was the case, and I was in the room with this patient. But it does obviously recover. The baseline does become stable again at 160, and the variability does remain normal.
I
agree
again,
with you. Yeah. Mr.
Yeah.
Nagib, sorry, I was thinking even the classification of this CTG as suspicious, I think is abnormal, isn't it? Is it suspicious or abnormal? Because this baseline here is going beyond 160 now, and we're having shallow decels here for most of the contractions. This is actually an abnormal CTG. So that's what I think anyway, and I stand to be corrected. So I'm thinking, yeah, Kara, you're right. If we're still pushing for vaginal delivery, we need to stop this into, but really, we should be delivering this baby at this point. We should be delivering this baby now. Yeah, that's what I think.
Again, I second Emmanuel. This is an abnormal CTG on a background of choreo. So I am trying to push the baby, which is already infected, to hypoxia, which we know that these two together are not 1 + 1 = 2. They become 1 + 1 = 3 or 4. So I'm really I'm attempting hard to hurt the baby now.
I would agree with you both. Can we go to the next slide, please? So at this point, they reduce the Synto down to 6, and then 15 minutes later, or 13 minutes later, reduce the Synto down to 3 mils per hour. This was where I started to get slightly concerned, because we still have a baseline that remains at 160, and yet this baby is now, I would argue, a bradycardia for more than 15 minutes, because this baby doesn't actually recover back to its baseline from the beginning of this slide to the end of this slide, which is actually about 20 minutes long. I don't know if anyone would agree, but with also the reduced variability that we're getting in between and during these decelerations, this is where it starts to become even more concerning.
Again, the management here is slightly, I would classify as hypocritical. The hypocritical effect here is that you are reducing the Synto, and what do you want to achieve? Like, you want to reduce the Synto, and still you are thinking that you are going for vaginal delivery. I feel you are going right, but you are saying I'm going left. It is a confusing message you are sending to the baby and to the mother.
I agree, Miss. I think the problem is when a decision is made to augment a lady, like in this case, I feel like we're committed then to give a fair trial of Synto without thinking that this woman is actually very high risk. We don't know anything about her antenatally. We don't know whether the baby is normally grown. We don't know if there's IUGI. Just by symphysis pubis measurement at 40 weeks doesn't tell us a lot about this baby. Are we pushing a baby that's already compromised? So I feel like the Synto not being turned off and continuing is at the back of people being criticized for keep turning the Synto off. When the fresh eye comes, they'll ask and say to you, did you give the fair trial of Synto? Because Synto on and off with a progress of 3 centimeters for more than 2 days is another way of defensive practice of holding on to that Synto by as much as reducing it even in the presence of an abnormal CTG. I can understand why, but I don't agree with it.
No, I fail to understand why, to be honest, Petro. You are trying to tell me I'm ticking the box of giving a good try, but you are also reducing the Synto because you are concerned. So if you are concerned that 3 centimeters, why you are not delivering? It is a real hypocrisy here.
Yeah, and concern against the backdrop of what we said earlier, we have no information about this baby's growth. Baby is prom now. We've had chorioamnionitis obviously in this same CTG, and then we're getting to this point, turning off Synto and leaving the baby there is not really helping the baby in any way. So if we're turning off that Synto, we should be telling the parents clearly, we've gotten to a point where we need to bail out in terms of recommendation now. We need to deliver this baby by cesarean section, except to say otherwise. Tell them like that, and then, of course, we're still offering them, it's their choice to decide, but you are recommending that you are going to deliver this baby by cesarean section based on your clinical judgment.
I just wanted to add in, Dagmar's got no sound, but she's just emailed me. Her recommendation at this point would be to examine, stop Sinto and out. And I think I would agree. And also she's added that obviously we can give it a good trial of Sinto, but not if that is doing harm, because the first rule is to do no harm. Thank you. Can we go to the next slide? So blood pressure remains stable and her temperatures come down. Pulse is still raised at sort of 101, and our baseline is now sat at around 160, or remains sat at, 160. And it looks like we're getting another deceleration down to 140. And I think on the next slide, it does recover back to 160 again, if you're happy to go next. So is the baseline reducing, or is this an entirety of bradycardia? So the discussion is made with the obstetric registrar, and the plan is made to increase the Sinto to 6 mils per hour from 3. I believe that's what's done. So if we go to the next slide. Sinto's again increased to 12 at 13:33. Now this variability is quite concerning to me. I reckon that we're getting close to the point where we can draw this with a pen on a piece of paper. So that pencil tip variability. Not really quite sure what's going on here in terms of our baseline. Arguably sort of 145, 150, following on from those IV antibiotics, but difficult. Dagmar's shaking her head.
I think sometimes we like to maybe test the gray matter of the baby and see if it, if we can destroy more than 10 or 20%. So, like.
Yeah.
Cara, have we examined again, please? Have we made progress?
Nope, we haven't re-examined. But I think a VE is coming up, if I remember rightly. So you'll soon see.
Cara, just a quick question. Was the ward so busy that we are like theater was busy all the time, or we are
No.
running between instrumentals and like, is there something we can't see here?
No, so I was in this day, and when I came in the morning, it was incredibly busy, and we had 5 women on the central monitoring, all of which that were a little that weren't perfect. Let's put it that way. They weren't all normal CTGs. There was a lot of sort of confusion with a few of them. But all of them had delivered by this point. I'm pretty sure at this point, this woman was one of 2 women on the CTG. The other was completely normal, and she was just starting an induction. So human factor element of this was that the unit wasn't very busy at all.
Or was she refusing the recommendation for delivery?
No, she wasn't refusing the recommendation. The obstetric team on this day were happy to continue with Sinto, so that's what they did. It was escalated to the consultant, which you'll see coming up in a few further slides. So yeah, but the human factor element here is that actually there wasn't major concerns with this trace. We go to the next slide, Dagmar, if that's okay. So she's moved to left lateral and the fluids are increased. So I think she's still on the second bag of fluids to 250 mils per hour, because that's obviously going to fix everything. Blood pressure still remains normal and temperatures come down. At 2 p.m, the registrar comes in for a review. This was actually requested by myself. The cervix was actually 2 centimeters dilated. Presenting part was -2. She had a kappa of +1. Was offered a cesarean section or to continue with Sinto, and the client requested to continue with Sinto.
So the V actually went down from 4 centimeters, was it 3 centimeters to 2 centimeters?
Yep. So this lady, I think we're now on the third day of her. I think it's been over 72 hours of her remaining 2 centimeters. She's got an abnormal or suspicious or gradually evolving hypoxic trace, whatever you want to call it or classify it as, with a significant rise in baseline from the starting. Deep sort of chemoreceptor decelerations, reduced variability for about 12 hours, arguably. And we decided to continue with the Synto.
Let's continue, Cara, because all of us now are failing to comment. So
Yeah. Let's go to the next slide.
Mr. Nagib, do you mind me asking you a question about this?
yes, please, boss.
I would like to find out, because like I was trying to say earlier on, we don't decide for patients. We know that. We give them the options and they decide. However, if you are in a situation where, because again, when we are doing we know that there are differences between recommending something and then, telling the patients about the options for them to decide. In this kind of scenario, should we just be telling the patients about the options available, or should we actually be telling them, this is what we are recommending? However, we know that these other options are available, but I think because of so and so, we were recommending that we should bail out now about vaginal delivery and go first. Can't we talk to patients like that? Is there anything wrong talking to patients like that?
I wouldn't put it in a paternalistic way. Patients in general and some specific people wouldn't like you to tell them you must. But I would definitely say,
no, sorry, Mr. Nagib, not must, but in terms of, when we're doing the MRCOG, there are places where they'll say recommend, okay, or offer, and then they will say you give the options. In terms of recommending, because there are places where you say, this is what I will recommend in this situation. These are the options available, but based on what is happening, this is what we will recommend in this kind of scenario. But if you say no, this is possible. However, the effect of that is this, and if you pick the option of vaginal delivery, this is the possible risk, and this is going to be the benefit. But if you're asking us, this is the recommended thing to do in this kind of scenario, and this is the reason why, that kind of thing. That's what I'm saying.
Yeah, I would agree with you. I wouldn't be giving options or offering options. I wouldn't put it like this in my documentation. I would say discussed, for example, I'm documenting now, discussed with the patient that the baby is distressed, going through so and so and so and so, and the best option in my view is to deliver now in view of the high risk of brain damage and so on. I wouldn't put an alternative and say, or the other option is to continue. I wouldn't like exactly seeing a lady with previous 3 myomectomies, for example, who is asking you for a fourth myomectomy. I wouldn't be sitting in the clinic and giving them the option of a fourth myomectomy personally. And even if they say to me, I want a fourth myomectomy, I say, as a clinician, I am sorry, I am not going to offer this for you. You can ask another clinician. So there is limits to what I can do as a clinician, which I am responsible for in front of my conscience and in front of the GMC if I am questioned.
Yes. Thank you. Thank you.
I'd also just like to add, Dagmar, I'm just going to read through Dagmar's thing in a second, but I was actually present for this day and obviously expressed my concerns for this case. Just wanted to point out something. The CTG this is what it looks like on the central monitoring system. When you have a case where we always do our fresh eyes when we go into the room with the patient, and that's absolutely best practice to go into the room with a woman and do a fresh eyes with the midwife that's caring for this patient. However, just because it looks better in the room doesn't mean the overall clinical picture has improved. And this was something that was identified on that day in particular. And Dagmar's just sort of said, other than VE, scalp stimulation, or vibroacoustic, we don't have reduced variability or wandering baseline. These are signs of essential nervous system problems. Choreo, prolonged SHROM, primate with no antenatal care. And she's just said that one obviously has to recommend a cesarean section, not offer, and clearly document words like brain injury, neonatal admission, HIE, and death, because this obviously could come up as a serious incident later down the line. And if it's not clearly documented, and this is our CTG, we could have issues. So anyway,
So whether Cara, you as a person were concerned or not, I can say and confirm to you that the team themselves, whether they say it to you or not, they are concerned as well. Cinto was reduced, then Cinto stopped. This is a team who is concerned about the CTG. It is not that you are saying something that is contradicting what they are thinking, but I think as a clinician who doesn't want to proceed for the cesarean, you try to find a leeway of waiting. And sometimes you try to satisfy. This is, again, maybe I'm talking about myself. I don't want to talk about others, so nobody is offended. Maybe it is the ego of the midwife, ego of the doctor who doesn't want. But what really hurts is that our ego sometimes leads to a brain damage or a substandard brain that in the future will manifest. And we satisfy ourselves by delivering this baby whenever it is delivered. And we say, look, the gases are fine. Yes, we know that this baby is not overly hypoxic, but we are agreeing that the hypoxia plus the choreo is damaging the brain. And the second thing that we agreed on a long time ago is that we are going nowhere. Yes, if I was 3, then 6, then 8, I have a little bit of an excuse. But I was 4, 3, 2, and in 2 hours I'll become cervix closed again or whatever. I can't see where is the rationale of the waiting, because we need to deliver people and deliver the baby safely. That's it.
That's correct. That's correct.
absolutely. Dagmar, can we go to the next slide? So the consultant came to review, the consultant on call, and agreed to recommend Cinto. So it was restarted at 12 mils per hour. I'm just aware of the time, guys, so I'll speed on a little bit. Third bag of Hartmann's has started. Her urine output was reasonably normal. There was no concerns with it at all. And she was turned left lateral at 15:09. We go to the next slide. So the registrar comes in to review at 3:30. The plan is for examination at 4 p.m. with a plus or minus of a cesarean section. Mum's blood pressure's gone up slightly again, and temperature of 36.5. Cinto still at 12 mils per hour. We continue. Cinto still at 12 mils per hour and good resting tone is palpated. The consultant and registrar report a normal trace, so in view of this, to delay the examination until 6 p.m. And they've also noted meconium stained liquor.
So now the third harmful stimulus of the or like deteriorating stimulus to the brain has come into picture, which is meconium, and we are still continuing.
Yeah.
Which you know, like sometimes comes under the category of like yeah, fine.
So we still continue. If we go to the next slide. Baseline's gone up again to 160. It stays up there. Go to the next slide. So she's septic again. Now temperature is 37.9, so some more IV paracetamol is given. Baseline's now on the increase to 170. Anybody want to intervene? Anybody want to deliver this baby? Yeah, Dagmar's saying.
No, I think, Cara, we should continue Sinto for another, like 2024 maybe. Yeah.
Nope.
This baby should have been delivered like last year. Yeah.
Yeah, this baby should have been delivered an awfully long time ago. If we go to the next slide, variability is decreased as well, and then at 6 p.m. she's examined. The cervix remains 3 centimeters, so I think finally the decision is made to go to theatre. If we go to the next slide,
Can I just ask a question? How long has she been in labor for? How long has this been? How many days is this now?
this is now I think 3 days she's been in. So she's 40 plus 4, and she originally presented at 40 plus 1 or 40 plus 2.
Okay, thanks.
So it's well over 72 hours, and her initial VE in triage was 2 centimeters. So she's remained 2 or 3 for 3 days.
So sorry, Cara, what prompted the sudden decision? I didn't capture what, despite all what we say for the last 6 hours, what suddenly prompted that we go for cesarean?
The fact that she remained the fact that she remained 3 centimeters.
Right. So it is a failure to progress.
Yeah.
Okay, fine. So the decision is due to failure to progress, not due to concerns about the baby.
I think that was the primary reason. Yeah.
Okay.
She comes
But even there, Mr. Nagib, I thought that the diagnosis of failure to progress even was made long ago, because I mean that baby was 3 centimeters, 2 successive vaginal examination, 3 centimeters, and then it came down to 2 centimeters. That was that was long ago.
I know. This is what I was trying to establish. What exactly is the real reason that made the team suddenly realize that we are going to deliver? I just wanted to understand how people are thinking, really.
Yeah.
So at knife to uterus, they noted offensive liquor with complete pus in the abdomen. So apparently this cesarean section, the baby was delivered okay, but when they cut through the uterus, apparently it was incredibly offensive, with lots of meconium and pus. That
is not surprising at all.
No, not surprising at all. So obviously the placenta was sent to histology. I haven't got the results of it back yet because they do take a while. And this case was reasonably recently. So yeah, does anyone want to guess the APGARs and the gases?
Actually, I would guess 7.2 for both. Above 7.2. Because the CTG seem to be having 9 live, but that's not the issue. Like Mr. Nagib said, it's not just about the APGAR, it's a combination of issues. So we have chorioamnionitis, hypoxia, and then meconium. These are all dangerous to the baby's brain. It doesn't mean the APGAR will not come out normal, or the cord gases will not come out normal, but it doesn't preclude possible injury to the baby's brain.
That's what it says.
Okay. So Dagmar's commented, this baby will be fine. There's no hypoxia on gases if noted, I believe. It might have breathing difficulties just due to the infection and the meconium, and obviously the baby will need a screen and treat. So if we go to the next slide, Dagmar, I'll put you out of your misery. APGARs of 9, 10, and 10. This baby's gases were actually completely normal, which was fantastic. But the baby was screened and treated in SCABU for sepsis, obviously. The CRP was 6, and it was actually uptrending after that, which is obviously to be expected. when going through such a long, drawn out process as that. But yeah, I thought you might
Yeah,
enjoy.
Yeah, by the way, saying that baby was absolutely fine, I don't think is completely right, because I mean, what we have done, or we will not know till the baby goes to his or her GCSE levels, really, and the level of IQ and whatever. Maybe everything will be fine, but maybe not, because 12 hours in a septic environment and pussy surrounding is not something that is very helpful, really. So yeah, baby is fine from the maybe the medical legal point of view, but if in 16 years they say baby is not achieving in their GCSE levels, and I'm seeing it coming anyway, they can draw the CTG and see, and they can sue for such a CTG. Yeah, which I'm sure the way we are going with litigation in this country, we will reach somewhere there soon.
Absolutely. I thought you'd all enjoy that one. I thought that one would spark a bit of a debate. So yeah.
The good news, Cara, that it sparked a 100% agreement on the management. So
Yeah, which is very nice. I think we were all very much in agreement. I think I was a little bit early in wanting to deliver, but actually, the baby was born in the right way. In the end, it's just a shame that it did continue for so long, when actually this could have easily, well, the meconium.
I'm sure it was so stressful for you as well.
It was actually, it was quite stressful.
Okay, sorry. Just let me just ask this question, Mr. Nagi, because I mean it's also on this patient, but not related to the CTG or anything. Hello, Mr. Nagi.
Yes, I'm listening, my friend.
Oh, okay. So yeah, so this lady presented to us. If I remember, sorry, I joined a little late, but I think I caught that part where Cara said she joined us. She came to us in triage at 40 weeks and 1 day, I believe, unbooked.
Yeah.
And then she was sent home. Yeah. So, Mr. Nagib, I think I got that part. She was sent home, I think. Yeah. So, Mr. Nagib, my question really here is this. Usually when we get unbooked patients earlier in the gestation, we try to, especially if they or late bookers, we try to induce them at 40 weeks. So if I don't know whether you practice that, but I know that some consultants practice that. I think, Mr. Nagib, I think in your clinic as well, I've taken that decision with you before. I'm not sure, but I think so. So this lady that came at 40 weeks and 1 day, do you think we should have let her go home, or should we have offered, maybe better put, should we have offered induction to her at presentation in triage after we have done the antenatal, of course, antenatal blood screening test, and then did she have any scan with us, Cara?
No, because at this point, Emmanuel, she came in at 40 plus 1 or something, so they weren't able to get her a scan. Also, she was contracting.
Okay, but at least she had some blood done, the usual. Yeah. So after doing those basic things, Mr. Nagib, my question is, should we have sent her home, or should we have offered her induction, considering she came at 40 weeks and 1 day?
So to answer your question, which is hypothetical, definitely, is if we are, me and you, in this same situation, I would say that because like, leave alone that she is unbooked with us, she is not booked with us. Leave alone that everything is done in a hurry and 40 plus 1. And we don't know whether she is really 40 plus 1, because this estimation, I don't know where is it coming from. Is it from her, from a scan, from somewhere else? When she comes to present to me in triage, let's say I am the registrar seeing her in triage, 40 plus 1, unbooked, this. I would err to the side of the caution and don't let her, I don't treat her as a low risk, which is sending home and being so relaxed about it. I would
Yeah.
treat as a higher risk in my head
Yes.
for the simplest reason that I don't know any information about this baby. And I agree with you. We have done this decision together in the clinic, and I would be more inclined to act more than being so relaxed about it. Yes. Number one. Number two, a point that I want to raise that I am seeing day in, day out, to be honest with you, and is contributing to chorioamnionitis. And me and Cara realized that chorio is coming like a monster to attack all of us all the time in Croydon, to be honest with you. And people are so cozy with choreo to the point that I feel sometimes that choreo, oh, is it choreo? Okay, yeah, get me the next one. As if it is a very common, ordinary finding that everybody is choreo. And we are missing a lot of baby, and we are leaving the babies to suffer till the point of, okay, it's about to die, let's deliver. So we are doing a poster, and hopefully soon we will do a poster about choreo to remind everybody that the bad effect of choreo and how the people who are reluctant should wake up and see the choreo as one of the major monsters for the baby, including the meconium, including hypoxia. The third thing is something I noted as a management of most consultants, most midwives, most registrars in Croydon is SHROM or rupture of membrane at term, send home and come in 24 hours. I'm not saying it's wrong. I am saying that the recommendation of the NICE, of everything that came recently, and of an SI that I was involved in writing, not involved in the actual care, is somebody with SHROM, it doesn't come as a default to send home and come in 24 hours. No, we should document in the notes that we discussed clearly with the woman that there is options. One is immediate induction, which is going to, like increasing the infection, but the
Active
disadvantage,
management. Yeah. Yeah.
Mr.
active
Nigib,
management.
sorry, Mr. Nigib, may I interrupt you? Our guidelines are in triage, if a low risk lady comes in with SHROM, we don't even have to do a CTG. Literally, we're listening for 60 seconds, give her the leaflets and send her home. I have
No, no, no.
no,
This
But a high risk
what,
lady.
but this what I'm saying, Petro. That whether it is high, whether it is low, whether that there should be, and I'm going to revise the SHROM guideline because there should be a documentation of a discussion of if she's strong, I can induce you now or augment you now with the advantage of decreasing infection, but the disadvantage that your cervix is not ready, or send you home with 84% going in labor in the next 24 hours. Yes, but with increasing risk of infection. Which one you want? Rather than implying on every single woman that comes that she doesn't have option. So these are the
I think, Mr. Naguib, sorry, I think if that's the case, we're going to have to change the protocol because we are as Petrona said, sending women home or listening to, for 60 seconds. And if they're low risk, they go home and come back in 24 hours.
Mm-hmm.
No,
And
I'm
remember,
not
Indra,
saying
some women
I'm
that
not
have
saying
delivered in
it's
other
wrong,
countries,
Indra.
sorry, Nagib, some women that have delivered in other countries, perhaps, like an example of somebody who delivered in India, will come in expecting to be augmented straight away, expecting to be delivered even, because they don't give them time after they've SHROM. and it's explaining to them that, oh no, in this hospital we don't do that. You go home, and they're like shocked.
I'm
Very
not,
true.
Indra, I'm not saying listening for 60 seconds is wrong or sending home is wrong. No, what I want to say is document that there is
Mm.
two options. And even I can
I
go.
think we're not giving clear, informed consent about it. We're not explaining the risk to the women.
Exactly. And I will go one step further as well. I'm sorry to say it, Indra. When I was doing the a document that Manjit gave to me to give to the Department of Health and give to uh, the HEE, Health Education England, and I don't know what. It included 400 bullet points, and I was going through them, and one of them is: do you offer cesarean section for Shrom? You know, and so what I want to say is, if somebody comes with Shrom, they have on in the book now, in what we should discuss. Number one, immediate augmentation. Number two, augmentation in 24 hours. Number three, which we never ever talk about, is cesarean section. These are the options that every woman should have the right to know, not that she has only one option. Bye bye, come tomorrow.
But I do agree, yeah, we should give them, we don't give them that choice. We give them the leaflet. We explain to them if there's changes, we give them temper dots, and we send them home.
Dagmar's just put in the chat, there's a national guideline that declares the options have to be discussed with women. You have to discuss document the discussion about the red flags, when to return or contact hospital. And many low-risk women would prefer to take their chances to go into spontaneous labour. And if indeed the first 24 hours, then they stay on IIA.
Exactly. This is national guidance. We follow. We are liable. And I see them in the debrief clinic, they say to me, "Oh, we didn't know that we have the options of doing so or so or so. We were only told, go home, come in 24 hours." And I am definitely, like Kara with the poster of Koryu, we need to change the Shrom thing, because I see now every week in, week out, Koryu. And as I said, people are becoming so as if they are drinking water. Like they even cannot feel that we are seeing something new. Oh yeah, get on with it. Another choreo, that's fine. Oh, put Sinto on. And it is becoming as if it is a normalized wrong. Yeah.
So yeah, maybe we do need to look at the guidelines and change it.
Mr. Naguib, Dagmar's said in the chat, subclinical.
Say something. Yeah. I can see it, Kara. Can you repeat it?
Yeah, Dagmar's just put into the chat, subclinical or clinical choreo.
Subclinical or clinical what? I'm missing the question.
Chorioamnionitis.
No, I know, but what is the rest of the question? Subclinical or clinical?
What would you define this case as?
Oh, it was obvious clinical, because the temperature was how many times? 37.9. How many times did you get that?
Twice. Well, over 37.53 times.
So that's clinical.
Cool. I've got a lot to add.
And more so, intraoperatively, we saw pause.
Yeah.
It's clinical. besides talking about the CTG also. So everything CTG, 2 temperatures, pulse in the uterus, intrauterine. That's clinical chorioamnionitis. Subclinical is when
No, I am sure Dagmar means something else, but I'm sure she's asking about something else, but I can't get it on my phone. The comment.
She's just put in, what do you have in locally, as subclinical is highly disputed, but really offensive or temperature of over 37.9 is actually not not that often.
The answer to you, Dagmar, I can't remember and I don't know. I need to check, Dagmar. I need to check. And actually, as I said to you, or I said to the meeting here, I need to check and change the way people look at it, at the SHROM, because it is so many coming through, and none of them, Dagmar, gets induced in 24 hours as we promise. Many go to 32, many go to 40. I don't, yeah.
There's a good paper indicating choreo and hypoxia and temperature in combination increases CP by 78 times.
Absolutely, absolutely. You know, like myself and Dagmar worked together in multiple hospitals, and we have seen it now and again. And it is good to have a paper to support it, but we have seen choreo plus hypoxia augmented by 70. Possibly this is what they reached, but choreo plus meconium plus hypoxia, I don't know, maybe 100, I don't know. It increases so much. Yeah. But thank you, Kara, for the case and for bringing this up and for bringing the discussion. It is very fruitful, not only for the CTG, it is for the overall management and for trying to use this to change guidances. So please, let's actively work together on changing this guidance and do the poster as soon as possible.
I will add it. It's on my to-do list. Don't worry.
Yeah, yeah. Thank you.
Thanks, everyone.
Thank you, Karen. Thank you, Mr. Naguib.
Thank you, everyone. Thanks.
Thank you. Thank you so much. Thank you.
See you next week.
Thank you.
Everybody.
Bye-bye.
Bye.
Thank you.
Bye.
Bye.